Hello, my name is Dr. Walter Reinisch. I'm from the Medical University of Vienna and working in the field of inflammatory bowel diseases for about 30 years. And it's a pleasure and a privilege on behalf of the collaborators, sponsors, to discuss and talk about our study today. The implementation of sample reading is a major achievement for clinical trials in patients with inflammatory bowel disease, aimed to harmonize and standardize the process of assessing endoscopic activity, curbing placebo response rates, increasing effect size, and render results across studies more easily comparable. However, we are still observing quite some variability in point estimates of endoscopic response and remission to placebo, both in induction studies of Crohn's disease and ulcerative colitis. So usually that variation is explained by the heterogeneity of patient populations and underlying concomitant treatments, as well as inter-reader variability. However, we as authors still believe that there must be something else. For the etrolizumab clinical trials program by Genentech Roche, we had the opportunity to establish a sample reader review board composed by highly experienced sample readers working in the field for 6 to 15 years of experience and having read at least 4,000 IBD endoscopy videos each. So the board contributed to the reader charter, devised training programs, performed regular alignment sessions of equivocal cases, and pondered in collaboration with the sponsor and the vendor of sample reading on study ideas around sample reading. And as a group, we hypothesized that different sample reading paradigms might impact placebo response and remission rates, as well as treatment effect size. We used data from an exploratory cohort of the ongoing phase 3 BERGAMOT study to conduct a comprehensive evaluation of the performance characteristics of 5 endoscopy reading models and their impact on treatment outcomes in patients with Crohn's disease. So these reading models included a local reading model where the local reader's assessment on the simple endoscopic severity index of Crohn's disease assessment was considered the final score. A sample reader 1 model where the first sample reader's SC-SCD assessment was considered the final score. Then there were 2 sample reader models where the local reader and 1 sample reader assessments were compared. If there was no agreement with one of those models, then a fixed difference was triggered an assessment by a second sample reader, and there was a second sample reader model where the local reader and the sample reader CD assessments were compared. And if these 2 scores did not agree according on the sliding scale, then a second sample reader came in and the assessment was compared with the local and the sample reader. And finally, there was another model where the average of 2 sample readers were considered for the final score and then rounded to the nearest integer. In total, we assessed 535 videos, and we found that models that are involving at least 2 readers demonstrated consistently lower placebo rates than those using only a single reader. Furthermore, we found out that treatment effect size based on endoscopic improvement was highest with the 2 models incorporating the local reader and 1 or 2 central readers. So therefore, we can say that the local reader is important in his or her scoring, and that any combination of a local reader plus 1 central reader, either as a fixed model or a sliding scale, to result in lower placebo response rates and higher effect sizes. So overall, the local reader was highly important, and in over 50% of times, the local reader accounted for the final score. Based on our results, we can say that not all central reading is the same. And we also can say that local readers are important to be implemented in a reader paradigm in clinical studies of Crohn's disease. We would wish to validate our findings in other data sets with other drugs, in data sets on maintenance trials and in patients with ulcerative colitis. Thank you for your attention.